Welcome to Centered Presents The Future of Health. I'm Dr. Molly Brown. Here, we explore brain-based wellness, nervous system regulation, and what it truly takes to restore your health, not hack it. Each episode offers insights, conversations, and practical tools and solutions to help you build resilience, clarity, and a sustainable high-energy life. Let's begin. I'm excited to introduce Dr. Michael Lim of Stanford University, Neurology. This episode is about clinical judgment, knowing when to intervene, when to support healing, and how different approaches can collaborate and ultimately work together. Dr. Lim practices at the highest level of neurosurgery, treating complex brain tumors and neuropathic pain. Today, we'll explore how he approaches surgery, pain, recovery, and collaboration, and how using the right tool at the right time shapes outcomes. Welcome, Dr. Michael Lim. I'm thrilled you're joining us today.
Thank you so much. It's an honor to be here.
Aw, thank you.
Yeah.
Okay, so tell us a little bit what your area of expertise is and what your approach is.
Sure. So I'm a neurosurgeon here at Stanford, and I have, as you mentioned, an expertise in two things, brain tumors and trigeminal neuralgia. And my career started off solely focused on brain tumors, but I have a particular interest in taking out tumors in what they call the posterior fossa, which is the back part of the brain. And as part of my practice, I also took care of patients with trigeminal neuralgia, which is a type of face pain condition. And that surgery also happens in the back part of the brain in the same area. And as I've gotten to take care of patients early on, I found a great deal of meaning being able to take care of those patients. For the patients with trigeminal neuralgia are in a lot of pain, and they're suffering a great deal. And to do that surgery and to be able to potentially cure a patient of that pain was something that I found, again, great meaning in. And over the years, I really took a specific interest in trying to help patients with facial pain. And that's why now the trigeminal neuralgia practice is also a big part of my practice.
I mean, that's a specific type of pain that's like a level 10 pain, correct?
Yeah, I mean, if you look up at this type of pain, historically, we've known about this a long time. If you actually look back at literature, for example, in the book Moby Dick, one of the characters actually had the pain, and they described how much that character was suffering.
Wow.
And in that book, they call it tic douloureux, which is the other name for trigeminal neuralgia.
Wow.
And I mean, for the patients who suffer from it, I mean, patients say it drops them to their knees with the type of pain that they're experiencing. And unfortunately, people have even committed suicide because of the pain that they're enduring.
That's horrible. So I know you have people call your office from all over the world, right?
Yeah, I do have patients that call asking for help.
And what qualifies them for your care? Like when do you decide that you can help somebody, and when do you say, this is not the solution for you?
Well, I mean, as I've learned over the years, pain is what I call a multidisciplinary approach. It requires a team of people. And when we have someone reach out, and someone reaches out to us saying that they're having a great deal of facial pain, if it's something like trigeminal neuralgia that I can help them with, of course, we talk to them about the options that are available to them that we can offer. But we also strive here at Stanford to be able to try to take care of patients with facial pain that's not trigeminal neuralgia. And I get to work with a great group of pain specialists. It's comprised of people like Dr. Chang Kian and Meredith Barad, who, for example, have dedicated their lives to trying to take care of patients with facial pain that is including trigeminal neuralgia, but also patients without trigeminal neuralgia. And we have pain neurosurgeons here also, like Dr. Ashwin Ramaya and Dr. Vivek Butch, who have been mapping the brain to try to understand pain centers. And so, as you mentioned, when people call, we try to be able to, or we want the approach to try to help patients with facial pain. And if it's not something I can specifically help them with, I try to again get them set in the right direction with my group and see if we can try to help make a difference for them.
Even with a surgical approach, how often do you think there's resolution of that facial pain? Or is it sometimes, like you said, like, is it a different cause? And then how do you find that cause? And like, what is the success? Because I know it's just such a high level of pain. It's almost unbearable when people have the facial or the like occipital pain.
Well, it's a great question. I think if in the situations where patients come and they present with pain that's consistent with trigeminal neuralgia, and those symptoms are very specific. It's almost a very stereotyped descriptions. Patients say that their pain is sharp and stabbing or electrical, like they're getting a zap, and it's usually on one side of the face, and it's what we call episodic. It happens in an unpredictable fashion, or sometimes they know because exposure to a physical stimuli, such as cold wind or drinking or chewing on that side, can trigger this pain. Um, Patients usually start on medications, but if they can't tolerate the meds or the medications are failing them, then there are some surgical options, and that's when the patients come to see me. One of the important principles, though, with facial pain that I tell all my patients is that we don't actually know the cause of face pain in a lot of people.
Mm-hmm.
And we have some what I call associations and theories.
Like, such as what?
So, one of the thoughts is that in a certain subset of patients, there's actually a mechanical problem. Um, there's actually a blood vessel that's touching the nerve.
Okay.
And when the blood vessel is touching the nerve, as we've all seen the blood vessels, especially arteries, we see it pulsate. And imagine taking your hands or fingers and rubbing an electrical cord, and you rub that for many years. You can imagine the insulation stripping off.
Yeah.
When the bare wires are touching it, that manifests as that zap or sharp pain in patients.
Sounds terrible already.
Yeah, and it's again, it's a very tough condition for patients to live through.
Yeah.
But with a small surgery, you can go in there and you can literally pull the artery off of the nerve, and you can either put a cushion there to separate it. They call it a spacer or a pledget, or you can sometimes actually um, pull the artery away from the nerve and stitch it away using a sling or glue. We just do whatever is the best configuration for the patients. And in those patients, if that's indeed the cause, it's a dramatic effect. I mean, they wake up and I've had patients just look at me and say the pain's gone, and it's almost like an instant fix for the patients,
It's amazing.
and they're very happy.
Must be so fulfilling, right? To get that result.
Yeah, I mean, I think it's one of those things where patients have almost been living with this burden, um, and it's so gratifying to see that burden being lifted off them.
Yeah, because it's hard to sustain that level of pain. It becomes all consuming, right?
Yeah, I mean, I think as 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 you take an individual and you expose them to chronic pain,
Yeah.
um, it takes something away from that individual. I mean, um, it's something where people either live in fear of
Mm-hmm.
having attacks, or they just they can't find joy in the things that they're doing every day, are what my
Yeah.
patients tell me, because they either dread it or they're in fear of having that pain.
And it's such a disempowered state to live in that, like you just never know, right? And so have you seen in your experience anything that does help with a trigeminal pain? Is there anything that people can do in terms of lifestyle to minimize it? Like, have you found that over the years?
Yeah, I mean, I think as I've as I've come to appreciate the fact that we don't really know the cause of face pain, and there can be many different causes, I've seen associations. Um, some of my patients say that living a very stressful life um, is there seems to be an association with living a stressful life, and they say when they're in very stressful times in their job, the flares, what they call flares, or the
Yeah.
episodes of their face pain seem to pick up in frequency. Um, and at those points, I think I encourage lifestyle. Um, Reconsidering their elements of their lifestyle to try to decrease their stress. Um, I've seen also an association of people who have autoimmune disorders.
Okay, that
Yeah,
was one of my questions I was going to ask.
yeah. And I, again, I see lots of patients, and some of them have autoimmune disorders, and that seems to be related to either them having flares,
Hmm.
or sometimes when they present with face pain, that's like sometimes I think sometimes the first manifestations of their symptoms, because I encourage them to get, for example, an autoimmune workup.
Uh-huh.
And, more often than not, the patients who have that have more atypical facial pain. They don't have the typical sharp stabbing, but they have more of the burning, aching pain or constant pain. And uh, there has also been a subset of patients who've had trauma
Yes.
after a result of a head injury. They seem to have face pain, and there's also even it's written about in our textbooks. Having a dental procedure can sometimes trigger this.
Yes. Okay, so in that case, how do you refer with a dental? I mean, that can be difficult.
Yeah, I it's hard for me to say. I don't know if it's really the dentist or the dental dentist that caused the problem. I don't think that they're doing anything wrong to cause it. But the theory behind it is that as you have to open the person's jaw to be able to, let's say, fix the cavity or take out the wisdom teeth, um, you may the trigeminal nerve, which innervates part of the mouth, has to be, can move a little bit. And they say that many people think that it's not that it causes trigeminal neuralgia, but it just might bring it on a little faster in some life. They were bound to get the trigeminal neuralgia. It just may have been the straw that broke the camel's back, as they say.
That makes sense. So there's a trigeminal neuralgia, but then there's the glioblastoma. Is that it? That's also your scope of work, correct?
Yes, so glioblastoma and other brain tumors are
Yeah.
another focus of my career. And so glioblastoma specifically is a type of brain tumor that arises from the brain itself. I think you may have seen some uh, famous people recently having that. I think, for example, Senator Kennedy had one,
Hmm.
and it's a very tough brain tumor. It's a very aggressive brain tumor,
Yeah.
and I get to work with some amazing people in the field who are doing research on that, and I work with some great clinicians in our department, and it takes really a team of people to take care of that disease.
Is that on the rise, would you say, right now?
I think in terms of brain cancer itself, it seems like it's on the rise, but
Yeah.
I also say as we're getting older, we're just seeing more of people around us getting it. So I don't know if it's necessarily just a phenomenon of us just going through later stages in life as we get older and see people around us getting sick, or if the cases of cancer are rising. I think that there's a thought that the cases of cancer overall, as a whole, are increasing worldwide and in the US. And um, it's probably, I think many people are actively looking into why that's the cause. Environmental certainly is thought to be one of them.
Recently, or maybe about 5, 10 years ago, we had a couple of cases with children of glioblastoma. How often do you see that?
So pediatric tumors, as a whole, are one of the more common cancers, unfortunately, in the brain. But again, that's still very rare. And pediatric glioblastomas are, um, I would say, much, much rarer than the adult version. And usually there's a genetic link for those.
Do you see it concentrated in a certain area sometime? Because I feel that if there's an environmental insult, I'll see like the cancer skyrocket. Is there any correlation with certain areas that you see more commonly?
I think historically we know that there have been what we call hotspots of cancer around certain areas, and there have been thought to be strong, what they call epidemiological links, where they don't think it's a coincidence. Don't quote me, I think it was called Love Canal in the Midwest, where there was a spike of cancers that may have happened. And I believe there was a plant that used a lot of chemicals, and they saw a
Yeah.
spike in cancer. And so there are certainly environmental factors that seem to cause cancers.
I read one study where there's radiation or cell phone towers. Are you seeing anything like that in your experience, a correlation with that?
Well, for example, there was a famous study with, let's say, a meningioma, which is a more benign type of brain tumor, but they can arise. They rise on what they call the dura, which is the skin covering to the brain. And I believe in the 1960s or 1950s, there were children treated with radiation for ringworm. And I believe it was an Israeli study, but at that time, uh, they just gave a very low dose of radiation to kids who had ringworm to kill the ringworm. And when they followed those kids out, they had I believe, almost a tenfold increased risk of developing a meningioma compared to the general public. And so radiation uh, is thought to have a link for cancer. But there are different types of radiation. I, I tell my patients there's something called ionizing radiation, which is a type of radiation that hits the cells and the DNA of your body, and they actually cause breakage of your DNA, or they call reactive oxygen species. It's like a physical hit. And that is believed or thought to increase your risk of cancer if you're exposed to ionizing radiation. Whereas there's another type of radiation called non-ionizing radiation, which is what cell phones use. And it's actually what your microwave works by, non-ionizing radiation. And that is not thought to work the same way as the ionizing radiation. And many people think that that has a lower chance of causing cancer. So a lot of research has been done on it, but the WHO, the World Health Organization, has said that there's a possible link, and that's right now the official word from the WHO, at least the last version that I saw a few years ago.
Yeah. So obviously, like you're at the top of the field with these very difficult and advanced aggressive conditions. So if someone doesn't qualify for the surgery, then where do you bring in a collaborative approach? That's how you and I know each other, right? So then you refer out.
Yeah, it's a great question. So when I think about pain and when they come to me, there's what I call the organic cause. There's, let's say, a problem with the nerve ending. There's the nerve sheath that might have been rubbed away, and that's the signaling that's sent to the brain to let you know that you are in pain, that you're hurting, and it's not a pleasant feeling to have. And then if you layer on that um, pain that becomes chronic and it's been there a longer period, and it's just not going away, there is a very strong psychological component that goes on top of that. And I think when you have that psychological component, it becomes a systemic problem for people. And when it becomes a systemic problem, I mean, it affects people from their mood down to stress level to the way they may even have interactions with their loved ones and friends and even colleagues. And it's a profound effect. And that is just as important to address, and they need help for that. But sometimes they don't even recognize it because it's just bringing them to that point. Um, And then there's another layer on top of that where if you live in pain long enough, it becomes what we call central pain. And the pain may actually just move from being in the face to actually having a pain center inside your brain. The analogy I give to people is that if you've met an amputee that has phantom leg pain, they don't have their leg anymore, but the brain is telling them that they're still having pain in their leg. It's because it's become central. That can be mapped out. And so when that happens, it's not just about fixing the nerve. And as a neurosurgeon, this is what we study. We study anatomy, and we're trying to get to the nerve. And we think that that's the problem. But sometimes there's much more to it that needs to be, that the patients need help with. And at that point, that's why you need a multidisciplinary group. And sometimes, I mean, the body is complex. And I tell this to my patients all the time. I'm humbled by God every day in my life. I'm not able to fix the pain in everybody, even the patients that have complex, I mean, have the classic trigeminal neuralgia. And at that point, they have two parts to their journey, is what I tell people: finding the cause of their pain and getting relief or improvement in quality of life to their pain. And they're two journeys. They don't have to be sequential. They can happen at the same time. And that again highlights the fact that we need to have a multidisciplinary approach. And in that journey to try to figure out the cause, I know for example, working with you, you are trying to help people find the cause of pain, but you're also working on the other aspect of trying to help the patients being able to deal with the pain mentally. And same with my colleagues here at Stanford, we have this great multidisciplinary group where our pain center is comprised of pain anesthesiologists, neurologists, an oral surgeon or a dentist, and a psychiatrist. That you have to be able to help these patients at multiple levels.
I love that you recognize that everyone has different specialties or maybe different solutions, and it's just a matter of matching up the right systems of care for that person, right? And so I feel like where it's lacking with some of the alternative methods is that maybe these systems have such great solutions, but there's no research around it. And that's where I feel like, a place like Stanford can really offer so much to create studies and actually have data on some of the alternative methods.
Yeah, I mean, I think there are good people trying to do research out there, and it's just sometimes. I mean, it's tough. I mean, unfortunately, no country has unlimited resources, and as the government has certain priorities and such, that sometimes it's a little harder to get funding for pain research. But I do know that there are good people out there doing it. I mean, I part of my career was at Johns Hopkins, and I can tell you that I have some great collaborators and people in the neurosurgery department that are still doing working hard on trying to understand the disease or the character of the disease, much like my colleagues here at Stanford. And we've made some headway in that. As an example, Dr. Rishing Shu, who's at Hopkins now, but on the faculty, but when he was a resident with us, found that there's the transcriptional network caused that seems to be upregulated by reactive oxygen species that makes trigeminal neuralgia patients more susceptible to pain. And it's an important finding, but each of these steps makes a difference in trying to help figure out that cause. I also think that doing the research on trying to help people emotionally and supporting them is important also in trying to figure out quality of life metrics. And as you said, as you have an interest in autoimmune disorders, immunology or the immune system plays such an important role in many disease processes. As an example, I focus on trying to use immunotherapies to try to fight brain cancer. The immune system interacts with the body in so many different levels that we're just trying to understand I mean, I think we've just scratched the surface on that, but that just highlights the fact that there's a lot to study.
So much to study. Do you see that over the long term, if people come in with a trigeminal neuralgia or the initial symptoms of pain, does it often an indicator to down the road any types of like long-term immune issues or cancer? Is that like the first symptom?
I say not necessarily, but what I think is important, but you have a very good point in the sense that, as an example, there are a subset of patients with multiple sclerosis that have trigeminal neuralgia. And it is now a very well-known association. And I actually have worked with a lot of MS neurologists, multiple sclerosis neurologists, to help their patients. And recently, a few years ago when I was at Hopkins, I was taking care of a lot of MS patients, and we found that, for example, rhizotomies work a little bit better than MVDs for those patients. Not to say that MVDs aren't effective therapies for those patients, but again, it's a collaborative approach that you mentioned.
Interesting. So MS can be considered an autoimmune. Autoimmune is such a load on the healthcare system. And I think when you're in that level of pain, you to some degree get disempowered, right? You're like a fixer, right? You're a neurosurgeon. So you just go in and fix. Like, do you see that getting people out of that high level of pain can then empower them to continue on a positive trajectory? How do you see that in your work, just empowering people through that process?
Well, I think what's important, what I've been able to see is that in the patients that we've been able to successfully help with pain, um, I always say at a policy level, you're bringing people back into society to be able to
Yeah.
help society and continue us moving forward together as for humanity, in a bigger picture. And that's what I always say: taking people out of pain will bring people back into feeling productive, and I think it gives them meaning. And when I've seen that, I've seen it in many different ways. People have been able to engage in their work and back into their career, whether it's um, whatever profession it is.
Yeah. Just being a contributing, positive, productive member of society.
And in other ways, what I saw is that some of my patients have become tremendous advocates for patients in pain, and they've done so much good out there. They've been out on social media talking about their experience and sharing their experience. They've been fundraising to try to help promote research or further research. Others have given online testimonials or webinars, and then it's really nice to see my patients doing this out of patient privacy. I don't say their names, but they're out there, and they've done so much good. I've seen patients, they've they've referred me patients. I know they've referred the patients to some of the local doctors there to help them. They've been able to really make a dent in that disease too, to help more people get out of suffering. And so I've seen it in multiple levels, but it's powerful once you can make people well again.
Oh, I think it's probably the ultimate too. Through the process of pain, the end result is you have an empowered, collaborative person who's connecting people that can help others, right? I think that's like the ultimate goal. And I love hearing this from you because I think that's why people initially want to become doctors or want to be in the healthcare profession, right? And that level of care for humanity is, I mean, ideally every doctor would have that, but it's not always the case.
Yeah, it's as I say to patients, it's our privilege to take care of them and try to help them get to a better place.
One of my like visions is that we can have this big network of doctors and health professionals that have different collaborative approaches to care and just openly refer. Do you feel that you have that in your area?
I mean, I feel fortunate that we do have a great group here with a multidisciplinary fashion, but um, I also think that with rare diseases, trigeminal neuralgia and the atypical facial pain are still rare, and they're a dedicated group of people across the country. And so, um, if there are situations where I can't help people, it's nice to know people across the country to be able to direct them. And I think one of the positives out of COVID is that we can do video visits, as an example. Uh, Congress has allowed, for example, us to have video visits, and if you have licenses in that state, you can see them now and help them. And I mean, you and I have collaborated, and patients have come to you, as you know, and I may have seen that patient in another state altogether, and they can still be at home and do the same, take their iPad out and have the same conversation. I mean, talk about their same condition with you as with me, and not have to fly. And um, I think what's exciting is the fact that the world has gotten smaller, information has gotten more, I mean, it's becoming more exponential. And I even think, like in the world of AI and machine learning, that it'll allow us to be more precise, and a patient may be able to figure out who can help them. But you touched upon an important point, which is that patients are sometimes the problem for patients is that when, for example, I have a patient that I can't necessarily help directly or cure, and let's say they're far enough away that they can't come to Stanford to see my other wonderful colleagues that I work with. They, the, One of the biggest things they tell me is that they need a quarterback. They keep seeing a doctor who says, "No, I can't help you. Try this," and they may get sent to an ear, nose, and throat doctor who says, "Well, there's nothing wrong with the back of your throat," or "There's nothing wrong with your ear," to explain your ear pain, and then they send you to someone else, and they're kind of at wit's end, and that only exacerbates I say it's almost a depression that they get. So you're right. I think as digital care is becoming more a reality, hopefully we can be able to offer more coordinated care in a national fashion.
Maybe that's one of the gifts of sort of the post pandemic. I mean, I just feel like healthcare is in a crisis, right? Since then, and there's so many inflammatory conditions. For me, I feel like it's also important to have the right personality match and trust the person you're working with, right? And so just being able to match people up with the right providers can be really powerful. And I think that's the whole key, is empowering people, like you said, like empowering people through the process of pain and the outcome of that. And that's, I think, where there's a lot of really good work to do.
I agree with you.
Yeah. So, anyways, I pulled a statistic about sort of the neurological decline, but 180 million Americans live with at least one neurological disorder, which can now represent one of the leading causes of disability. And so, being a neurosurgeon, just I feel like the brain health, right? Do you have any tips or any preventative measures that you use or that you work with in your professional environment for overall neurological and brain health? Like for you and your own family, what do you do for your own brain health?
Yeah, that's a great question. I have to say, I think when many of us are young, we don't think about that.
Nope.
And as we get older, we definitely think about brain health. And almost everyone has been touched by someone, for example, who's had dementia or Alzheimer's disease. And we realize how tough how tough that disease is for the patient and for their loved ones. And as you mentioned now, I mean, a lot of people are focused on trying to um, figure out ways to um, prevent that from happening. And I think it's happening from two fronts. One, there are more and more tests that people are developing to be able to predict who is at risk or who is likely to get Alzheimer's at an early age or dementia at an early age. And then there's the other part, which is to try to restore function. But if you can't restore function, at least slow that process down. And there are many shows, as you know, that are out there But to try to slow that process down, there's I think of two buckets. One, do we have an intervention? And there have been I think two drugs now approved by the FDA that have been shown to slow the progression of these neurodegenerative diseases when people start exhibiting symptoms. And with that, the question will be, should you take them even earlier? Or if you know that you have a genetic signature that predicts that you're going to have Alzheimer's, should you take it at an early age? These are all great questions that need to be asked in society. And then, is it that we need to take this vitamin to try to keep our brain going as much as possible? And that vitamin, everyone is trying to figure it out. There's people who've written about it just saying, well, my experience, or there's some scientific rationale for that, but that hasn't been vetted in a phase 3 clinical trial. And so I always caution my patients to say we don't have evidence. It's not to tell you that it doesn't work, but I think we need to be able to put some resources and maybe be able to test some of these supplements that are out there to be able to give patients the answer to do it. I think many people believe that things such as exercise and the diet or what you eat can affect general health, and that includes brain health. And so both of those things are things that I personally focus on. I'm trying to exercise regularly and maybe not eat a burger every night.
What about, is there anything of like in the longevity field that you are interested in? I mean, there's so much out there, right, with new things coming out every day. Is there anything that personally interests you?
Well, I mean, I think if we can, there's a lot of different studies that are coming out, and as an example, when your DNA replicate on the ends of the DNA are these what I call appendages that shorten, and it's almost like a clock, and as it shortens to a certain point, that predicts aging. And so people are focusing on trying to make those appendages, they call them telomeres,
Yeah.
longer. I've seen others focusing on trying to do things like the anti-inflammatory diet to try to improve their length of life and decrease the risk of chronic disease in their body. And I think, on the other hand, there's some good scientific data based on these antibodies that were developed by these companies that try to slow down aging. And I think we have a thread there, and if we follow that thread, we may be able to open a lot more knowledge in science and build upon that. And so my hope is that at least we have something we know, and we can try to follow that thread, and then try to encourage and try to do some sort of definitive clinical trial to show with statistical significance that some of these other interventions that we're doing or that's being put out there has an effect, and that can help society. But those have been the main things that I've been thinking about.
Is there anything you incorporate in your own routine?
Well, for me, I personally think that exercise
Yeah.
makes a big difference, and so I have to say, up till a few years ago, I wasn't really good at exercise. I barely ever exercised.
It's okay.
Um,
You can start at any age.
you can, and my doctor said 150 to 180 minutes of exercise a week, some sort of, even if it's just walking. And I feel like it's made a difference for me already. And so I've been pretty good about that. And listen, I love things like McDonald's and fast food, and I ate a lot of that growing up. And even in my early career years, but I have also changed my diet to be healthier. My wife has been super encouraging about that. She's very she reads a lot about health, and so that has changed also, and that's helped me, I believe.
It would be amazing in the future if we can have a completely integrated approach with sort of the simplest things and the most advanced things for brain health. I think it all comes down to brain health, right? And keeping your cortisol balanced, and which keeps the inflammation down. And that would be my vision. And I'm so grateful for this time to have spent with you. So thank you so much again for being on here. But to really, I love your approach of caring about people and working in collaboration and, doing your best for others, and the compassion that you speak about in your field. Because sometimes I feel like surgeons don't have that kind of that broader approach to their patients' care.
Yeah, I mean, I think that speaks to the bigger picture. Sometimes with the way we do medicine in the world, I mean, we created so many specialists. We just say, well, it's not something. I do XYZ procedures, and I can't help you. And the thing is, it's very complex. I mean, what I spent my whole life understanding the anatomy and techniques, and so it's not because we don't care. It's just that sometimes we're just stuck in our world and say, well, we can't or can't help you. But for the patients, we recognize that it's hard, because that means they're seeing 5 or 6 specialists and being told, nope, it's not me that can provide this care for you, and I'm going to try to send you to this other person. It's a hard thing. But I am hopeful that, as you said, precision medicine is on its way. And when you get your blood test, in a few years, I believe it, with the artificial intelligence that's out there, that they'll just be able to process so many different things and say, this is your inflammatory risk level, as you said. This is your risk for dementia, or this is your risk for all these other conditions. And not only are they going to just say these are risks, these are steps that you can take to mitigate these risks, to ensure that you do better. I think that's going to happen in our lifetime.
I love that. I love what you just said. I mean, the field of medicine and healthcare is so exciting right now, because there's going to be huge changes. And I would say in the next, like 5 to 10 years, where not only can we predict and prevent future problems, but we can actually completely avoid them. So yeah, that's actually like super exciting. So that's a great way to kind of sum everything up.
Yeah. The goal is to put ourselves out of business.
Yeah.
That's what they say.
Yeah, I know. That is the goal. Well, amazing. Dr. Lim, thank you so much for being here with us. And hopefully we can continue the discussion of collaboration and a network of care, and really create positive change in that as well, with Stanford and other universities and research. And there's so much potential for collaboration, which is like really personally exciting to me.
Thank you, and I believe that too. I mean, I think, I think all of us as a whole have realized that we can't be silos, and that we call it team science and team clinical care is really going to be important in making sure we give the best to our patients, and to push the field forward. So I wholeheartedly agree with you on that.
Thank you so much. I really love that. I love hearing that from you. Thank you for your time, and I love talking to you, and have a great day.
Thank you.
Thank you for spending this time with me on Centered Presents The Future of Health. Healing is a journey and relationship with your body, your nervous system, and your life. If this episode interests you, subscribe, share it, and continue the conversation. Visit us at drmollybrown.com.